Good morning, colleagues. I'm just going to take a second as I wait for my co-host. The other way. You're going to fall.
So tell who you are.
I'm Palesa Motsabi Chakani. I am head of Department of Anesthesia at VETS and the chair of the scientific program for this Congress, and my co-host.
I'm Jannik Mellin Olsen. I'm an anesthesiologist based in Oslo, Norway, and I used some years ago to be the president of the World Federation as well.
Thank you.
And for the beginning, we are also joined on the stage by Angela Enright.
Before we do that, as Angela comes up, we would like to welcome you to this chapter of the AAAC that is in South Africa for the second time in so many years. It has been a fantastic moment to see everyone from Europe, America, the continent come up to South Africa to come and join us in this very, very important meeting where we collaborate, we have discussions, and we find solutions together as a community in anesthesiology. Before we start, as Angela is coming up, I would like to just call the president of the ARS to come and open the Congress officially, as you know that the Congress is not yet open.
So we didn't do that yesterday?
No. You feel safe?
I do, and I don't have a handheld mic, so no one's taking this mic away from me. Thank you so much. It's wonderful to stand here. It's hard to believe that it was only 2 years ago that I stood in Kigali and asked that Africa trusts us to bring this conference here, and here we are. It's been so much hard work. At the gala dinner, I will thank all of those involved, but I just wanted to reflect a little bit on last night's Weinbrunn lecture. Yesterday morning, actually, a colleague of mine sent me this quote. It's by the COO of Standard Bank in South Africa, and she wrote an article for Women's Month, and she said, "The foundation of diversity lies in building trust, creating an environment where individuals feel empowered to express themselves freely. Understanding and valuing diverse perspectives ultimately cultivates a culture of trust and collaboration." I just want us to think about this diverse place we live in. In Africa, our diversity is our strength. It's not our weakness. Yet at times, because of our diverse backgrounds, we may offend each other, and most often when no offense is intended. It is at these times that we must touch each other with compassion, and we understand what compassion is. We must apologize, and most importantly, we must listen. We must listen to grow and improve. Let's treat each other with kindness, knowing that we all see the world from our own perspective, and that these perspectives may seem at times to drive us apart, but in our hearts, we long for deep and meaningful connection. Let's build those connections this week. I now declare the 2024 All Africa Congress open. Thank you.
Thank you, Gareth. On behalf of the WFSA, the ARS, SASA, the LOC, the Congress is open. Thank you very much. So our first speaker is going to be introduced by Janneke.
I was so eager to start here. Our first speaker, she actually doesn't need any introduction. She's Dr. Angela Enright, originally from Ireland, now living in Canada. She has been the president of the WFSA, she's been the president of the Canadian Society, and she's an emeritus professor of University of British Columbia. And very important in this setting is that she's also the executive section editor of Global Health in anesthesia and analgesia. And I think all of you who want to publish or do something scientifically related to this region, you should approach Angela. So you will be very busy during the Congress. Welcome.
So thank you very much, Janneke, for the introduction. And I'm sure you're wondering why on earth I'm here speaking. But, you know, when you come to visit someone, you always like to come bearing a gift for the hosts. And I'm thankful to the Host Society for giving me the gift of a little bit of time this morning to tell you about some things of interest. As Janneke said, I'm the executive section editor of Global Health for Anesthesia and Analgesia, and commonly known as the IARS, the International Anesthesia Research Society, is an old society with the ANA as their prime journal. And their mission has always been supporting international education and anesthesia research. There are many initiatives that they have over the years, but now, since we've started the Global Health section, and many of you have contributed to that, there's been a renewed focus at the journal and at the society on what more we can do to aid people who work in less well-resourced countries to improve education and anesthesia. So this morning I want to announce to you that for all of your trainees, fellows, medical students, membership of the International Anesthesia Society will now be free. All you have to do is go online and join. And for all of those of you practicing in low and middle income countries, you can now see that we have a tiered membership level, which should allow you to have membership in the IARS. And this will open up to you the journal and all our other educational offerings. It'll open up open anesthesia, which is a cornucopia of educational things, podcasts, videocasts, reviews, which you will be able to access. And we are very interested in having more people and more diversity in our editors and in our peer reviewers. So we are now offering 12 editorial fellowships available to everybody around the world. And for those of you who have an interest in journal editing, in writing, in peer reviewing, this is an opportunity for you to apply for one of those fellowships. We also are running now, and one of them is here, peer review workshops so that we can broaden out and diversify our peer reviewers. Many of you don't want to get into the full journal editing things, but you'd be very happy to be peer reviewers, and these will be in person and online very shortly. For those of you who have had your research accepted as an abstract for the International Anesthesia Research Society meeting, you can now apply for a travel grant to come to that meeting and present your research. And this is a big step forward to help you. And for further encouragement, the next meeting is in March in Hawaii. So I encourage you to submit your research to the IRS, and if you are presented, you can then look for a travel grant. And finally, and this is the big one, the IRS is dedicated to supporting research around the world. And it's been obvious to us for some time that people who work in low and middle income countries need a great deal of support. So for the first time, we're offering an international mentored research grant worth $50,000 US over 2 years. And this will allow someone who wins that to develop the research at their own center using, hopefully, local mentorship, but with international mentorship and support over 2 years, in the hope that you'll be able to develop a sustainable hub for research at your center. And so I hope you will find these gifts acceptable and useful and encouraging for you to become part of this great anesthesia community. Thank you very much.
Ladies and gentlemen, I think we need another round of applause. There are gifts, and then there are these gifts. In a society where we are striving to be researchers and clinician scientists, we are grateful for the offers. And I hope everybody who's an aspiring researcher will take up the opportunities. Round of applause again. Thank you. All right. Our next speaker is no stranger to all of us throughout Africa, throughout the world. He is the professor and second chair of anesthesia in the Department of Anesthesia in University of Cape Town. Bruce is literally synonymous to all of us, to kindness first, to research and collaboration. We welcome Bruce.
Morning, everyone. First, thanks to Anthony, thanks to Palesa for this opportunity. And it's very special to have this opportunity right in the first session of the main Congress. Also want to thank you, Angela. Angela's been a tremendous support for the work we've been doing in Africa. A lot of our work has been published in ANA, so thank you. And I know how difficult it was for you to navigate these grants, but that grant is phenomenal. It will definitely make a difference to someone, and I'm hoping someone in Africa, to start a big research project, so thank you. I've been asked to talk about research collaborations and mentorship. These are my disclosures. All our work is investigator-initiated and led. I want to thank SASA. SASA, until recently, provided some financial support to Safe Surgery, South Africa, which manages all our data repository for all the Apple projects. So thanks to SASA for that, because they have been instrumental in supporting the work we've done. And then, importantly, I want to thank all the people and clinician scientists across Africa who constitute APOC. There are lots of people here. I have the privilege to present their work. I've put up QR codes. That's how you can register on the APOC network. For registrations, we got clinicians from 42 countries now in Africa and over 1,100 hospitals and 1,800 investigators. These are registered. In reality, I think the number's way more than this. Just a bit of a background for people who don't know about the African Perioperative Research Group. This is the main contributions that we've made from a collaborative perspective: adult surgical outcomes, maternal surgical outcomes, kids in COVID, and now in critical illness. We've recruited nearly 72,000 patients across this network, which is a phenomenal effort if you consider these are clinician investigators who work in environments which are low-resourced, and this is predominantly unfunded research. And these are the main messages. Failure to rescue is a massive problem in Africa. That's death following a complication. You're twice as likely to have failure to rescue as an adult in Africa. If your mother, 17 times higher than high-income countries, and if you're a child, 4 times higher than high-income countries. And what does it translate to? Excess mortality. Adults twice as likely to die than the global average. Mothers 50 times more likely to die than in high-income countries. Neonates from cesarean sections twice as likely to die. Kids 11 times more likely to die than in high-income countries. In COVID, we had 2 excess deaths for every 10 admissions who got into ICU. About 50% of patients who were referred to ICU didn't even get in. And the critical illness study, which has just been completed and was submitted on Wednesday for review looked at all in-hospital patients, trying to look at what's the prevalence of critical illness. And all hospital patients, it's about 12%. And the mortality of those patients, so this is a single episode, it's not what happens through the course of the patient's stay, it's just looking at them once. Their mortality at 7 days is equivalent to high-income countries' mortality at 30 days. So this talk, it's a bit of a warts and all type talk. It's a personal story about collaborations. It's about resource and waste. It's about collaborations and priorities. It's about innovations, success, failure, and patience. So I've always been a nerd. I've enjoyed research. And in about 2015, there were a lot of small projects running in South Africa. I was really very keen on perioperative beta blockers, and I thought there was potential for change. But we had all these small projects, and there was no money. And I kept looking at our HIV colleagues. They had organized themselves. They would just had money pouring in. But we all knew people were dying in surgery, and we had nothing. And I thought what we have to do is we've got to make sure that we don't waste the limited resources we've got. And really what we needed is we needed to ask relevant questions. We need research designs which are good. We need to be efficient, and we need to get the message out. And so to do this, I thought we have to create a coalition, really, to say, show two things. One, that we can work together, because that's super powerful. And two, to show that it's not only patients with HIV who are dying, but patients who have surgery are dying. And so this started in South Africa, and with a lot of support from people like Chris Landrigan. I saw her earlier. I can't see her now. We managed to pull this off, and we did the South African Surgical Outcomes Study. And I think the success of that allowed us to get a group together to form a South African perioperative research group. And the whole object of that was to build a social contract. And so this is a slide from, it was about the 12th of September 2015, where we had been sort of crafting a message to try and get people to believe that if we do collaborative research together, we can make change. And we had these 10 principles, and we thought if people can buy into this, then we are on the right road to important collaborative research. I think these 10 principles still hold today. What we did after that, when a whole group of clinicians across South Africa agreed to work together, was to agree on what research we should do. And so we set about setting up research priorities for South Africa, and there were 10. I just want to show you what the sort of top few were. So it was critical care outcomes, B-natriuretic peptide, targeting to improve cardiovascular outcomes, pediatrics, maternal and fetal outcomes. The reason I show you this will become evident later. And you'll see there we've addressed some of these at a continental level now, and others we feel like we haven't even managed to make a little progress. I think what happened was from that initial meeting in September 2015, we realized that some of the work and the priorities that had come up should actually be happening at a continental level. And that was the beginning of the African Perioperative Research Group. Myself and Prof. Madiba, who at the time was head of surgery at KZN, we Cold Called Africa, which was emails, calls, through webs, through friends, and every time someone responded, we just asked them, can you connect us? And it was blind trust by clinicians across Africa to participate, but the result was phenomenal. And that ended up in ASOS. And ASOS was difficult, I suppose, because the message was so grim that patients were doing so badly. And, working through it and thinking about it, eventually, the simple story came up. It was, if you have surgery in Africa, you're twice as likely to die than if you have surgery elsewhere. Now, we were fortunate because what we learned there is that actually people care. So the public cared. It's a sort of signal that where people can say, you're not doing things right, you don't care, you're not looking after your patients. Or they could say, this is really important. There's a signal here, there's stuff we need to do. And from the outside, that was the public message we got. So it endorsed the work of all these clinicians across Africa. And then simultaneously from the clinician investigator group, what was really interesting was that I felt it empowered us. We had an insight into what was happening with our patients and maybe what we could do to change it. And I think there was an ownership of a problem, which was super powerful. So as Apple sort of started to grow then, we looked at what the priorities are for Africa. So we had started ASOS off a South African priority. And the reality is that priorities are context sensitive. And so these are the top two priorities for Africa: training standards for perioperative care and minimum provision care standards. And these are things that we always think are obvious and they're out there. And the reality is the standards that come through from high-income countries pretty much have no relevance when you don't have half the resources to deliver them. And so when you think about collaborations, you may have national priorities, and if you go broader than that, the priorities will be different according to the context in which people work. And what you also find is that priorities are responsive. So even though we had this list of 10 priorities, the first thing that came through from ASOS was that patients were dying, and they were dying on the ward, and it just felt totally distressing. You felt like if time marched on, we just have all these excess deaths, which we know are going on. And so as a group, the Apple group decided that we've seen the signal, which is failure to rescue, we need to address it. So that became a priority. And so looking for intervention to improve outcomes. And so how do you do a clinical trial and a big collaboration when you've got no resources? And I think one has to have the conviction to challenge conventions and be innovative. So in my sort of two nerd lives, the one nerd life is working with high-income countries and doing perioperative cardiovascular trials, which are well-resourced. And in those trials, what happens is maybe 40 centers are well-funded. You recruit for a year or 2 years. You make quite a big contribution to the database, and hopefully it results in evidence which changes practice. But in Africa, where we got almost no resources, the clinicians are doing the work and the research. How do you change it that you can get a sample size big enough to address the problem you're dealing with? And the reality is from ASOS, what we knew was that there was less than one clinician per 100,000 people, when the Lancet Commission reckoned we needed 20 to 40. And these are the same people who are doing the research, besides providing the care at about 20 to 50 times less than the number of people they should have. So we did this. We thought we needed about 60,000 patients to answer the question, if we increase postoperative surveillance, we can decrease mortality. And to do that, instead of having 40 centers, we said we would have 600 centers. And the 600 centers would work for up to 4 weeks. Once they got to 100 recruited patients, they could stop. And that was the plan, and it was totally unfunded. It was an epic trial and had epic failure. So we had nearly 30,000 patients, 332 hospitals, 30-something countries, and we had this. We had to stop because of COVID. So 30,000 patients, and we showed absolutely no difference in the outcome between the hospitals randomized to increase postoperative surveillance and those that hadn't. So the learning was massive. The first thing is, I suppose I was totally naive. A thing which I thought was a simple intervention is actually a complex intervention. So to provide increased postoperative surveillance to improve outcomes, actually what you need to do is you need to be able to identify the patient, you need to be able to provide increased surveillance, you need to then identify the deteriorating patient, escalate therapy, and it's got to be appropriate, and then you've got to actually hope that your patient's on a trajectory where you could change their mortality. Very difficult. We got no idea what we actually did for our patients, but we learned a lot. And what we did do, fortunately, was a process evaluation. So speaking to investigators at sites and asking them their experience. And I think what you learn is we know about research, but it's all built on people and teams, leadership, the stresses that individuals have in their own environment when they're at work. And until you unlock that soft core and you address what's important to the clinician investigator at the coalface, it's very difficult to go on to do complex implementation projects. So I think this led me to the next part, which was that patients are at the center of everything we do. So just to move away from the talk for a second, thanks to Sasa Karting, who've made the ebook available for this week. So if you scan that QR code, you can download the book on COBA, and it's in English, French, and Portuguese. So I think as a researcher, what we see, in a collaboration is that we can see problems and systems which are addressable. Science moves so slowly, particularly medical science. And but there are things we can do to improve patients' outcome if we start to think about those. So this, for me, this was just putting down the thoughts on what I think could improve patient outcome and quality of care. And if I'm wrong, that's fine, but it was more about trying to initiate a conversation. So I put my thoughts down in two systems, really. The one, this is what I call the inside-out model. So it's what happens from inside the hospital, and it starts with beliefs and values in people. And then knowledge and education, as you saw from the priorities for APORG, and then deliverable interventions. And then following those through processes, are we actually doing what we planned or set out to do? and then ultimately you are limited by your resources. On the other side is health system strengthening. So this is looking from outside into the hospital. And that's really this basic tension really that we have between the resources you have available and the processes that are supporting the interventions. So how do we go forward here with AppOrg? So from a collaboration perspective, I think AppOrg has matured tremendously over about the last 7 or 8 years. And it's going to be officially constituted this year. We have a meeting on the 2nd of November. If the right QR code, you scan that, you can join the meeting. It's virtual. But essentially, a board is going to be elected, which will have representatives from the 5 regions in Africa. And I think this will be a massive step forward in how AppOrg delivers across the continent. And then working on a mentorship program, so building an educational platform, and definitely the work that Angela showed with the open anesthesia. Similar sort of concept, so mentorship and education across the continent, and then using the data that we have to create a data repository that people can start to explore and then see if there's a question they want to ask, and then use those sub-studies to mentor future researchers. So that's hopefully where we'll be going from now. Thank you.
I think what you and your group is doing for global health, and this has impact for the whole world, not only for Africa, what you are doing, a role model. And it cannot be overestimated. Yeah, over. Thank you. So our next speaker is also a very special person. Is Professor Daniela Filipescu from Romania. You know probably that she's the current president of the World Federation of Societies of Anesthesiologists. She has also been the president of the European Society, and she also has one of the most analytical minds on this planet. And she's going to talk to us about surgery team missions. Do they equate to mentorship and skills development? Welcome very much.
Good morning, everyone, and thank you, Jannike, for the kind introduction. And I want to thank the organizers for the opportunity to participate to the All Africa Anesthesia Congress. It's the first time I attend this Congress, and I'm very honored to be in this first session of the Congress. I'm not an expert in surgical missions, but as a WFSA president, I have an opinion on this, and I will share with you. I'm a cardiac anesthesiologist in Romania, in Bucharest, in one of the biggest centers in the country, affiliated to the University of Medicine. Our center was visited in 1976, before I started my career, by Marius Barnard, from Groteschoor Hospital, and he really pushed the development of cardiac surgery in Romania. But surgery in general was a stepchild of the health system. It was mentioned in 1980 by Director General of the World Health Organization, Dr. Mahler, as an important part of the primary healthcare, but nothing happened afterwards until 2015, when the politicians started again to speak about surgery, that surgery, anesthesia, and obstetric care are essential part of every health system. And why about this interest after 2015? It It is a milestone year when there were publications from the Lancet Commission about the surgical global burden of diseases and the fact that 9 in 10 individuals do not have access to surgical care, that we need more than 143 million surgeries annually to be performed on top of what is performed currently, around 300,000, and that 95% of the population in sub-Saharan Africa has limited access to safe, affordable surgical care and anesthesia care. In this context of neglecting surgery, global surgery arose as an advocacy movement, which is defined as a multidisciplinary academic field that aims to deliver equitable access to safe, timely, affordable surgical care in all countries and for all who require it, with a special emphasis on underserved populations and populations in crisis. And there were some types of surgical missions, outreach developed in global surgery, including short surgical missions, also humanitarian efforts for disaster and crisis zones, but also some long-term efforts for developing a facility in one specialty, or also including training and capacity building. However, the short-term missions, although they cover a high volume of interventions, they have some drawbacks regarding education and training, sometimes included in these missions, but many times unstructured, and they are also expensive. But I have to commend all the non-governmental organizations worldwide which cover a huge surgical caseload. This is from a report from the period before COVID pandemic, and you see they are covering and providing more than 2 million interventions. It's true that 80% of them are in eye surgery. So there are many advantages of short surgical missions, besides providing direct care, but also improving skills, improving the health system in the country. There are also academic and career benefits, and allow broader collaboration. And this also raises awareness about the importance of increasing the capacity, surgical capacity in the country. These benefits were also captured in some surveys performed and published in the literature, and you see that 95% of respondents appreciate the positive learning experiences. However, you see mentorship opportunities are mentioned only in 37% of cases. But there are also drawbacks of the short surgical missions, besides those related to the short-term nature of these missions. Also, there is a perpetuation of voluntourism. There are also colonialist practices criticized. There is lack of regulation for these surgical missions. And I think what is very important is the failure to capture the quality of care. In fact, sometimes the outcome was not so good of these surgical missions, and there are not so many data about the outcomes from these missions, and they have, in some cases, no impact of the local communities, because they do not have patients' perspectives. They do not promote partnerships with the community, and sometimes they can reduce the incentive to invest more in surgical care. And these are in fact related to the challenges of unidirectional global surgery experiences, which were also, these challenges captured in some surveys. And you see, unfortunately, the surveys, the respondents are more frequently from the visitors' countries and less from the host countries, but you see that almost 50% of them perceive and feel the lack of balance exchange between high-income countries and low and middle-income countries programs. So the solution is probably having and developing bidirectional exchange programs with broader collaboration with visiting teams and integration of educational efforts. There are also some ethical dilemmas regarding these surgical missions. One important is how are the patients selected to have this access to the surgical missions, and is informed consent really informed if we take into consideration the language barriers, and also other important questions such as is ethical to perform high complexity interventions where more basic needs cannot be addressed in the region, and also what is happening after the surgical mission leaves. So that's why this vertical model of unidirectional development of programs for increasing the capacity, the access to surgery is less favored now, and everybody is talking now and developing more diagonal model in which the focus is on bidirectional relationship between those who are providing the program and the host, the community. And there are some organizational framework suggested based on the culture and coordination in the program, and which include very important pillars such as partnerships and promote partnership, professional development, governance, community impact, and finance. And there are some nice figures in the literature, but why I put them just to stress that now we see this surgical outreach as an ongoing process which should be planned, very well planned and analyzed, but this analysis should, and refined for sure, should be analyzed in a bidirectional way. So the norm is now capacity building, focusing on bidirectional partnership to educate and empower individuals and organizations such that their care for the local community is enhanced. But this means change. And this is a paradigm shift from the concept, how do I treat the patient in front of me, to how do I use the skills set to partner in a way to improve the lives of a community or a population. And this is possible by including not only skill transfer in these surgical missions, but also mentorship, because only through education and mentorship we can ensure the sustainability of local surgical capacities. And this is a new program I found in the literature for cardiac surgery. Now, cardiac surgery is also included in surgical missions, and this is a project for Mozambique, and you see mentorship is included, and the mentor site is Groote Hospital here in Cape Town, in South Africa. But I will not speak more about these missions because, as I told you, I'm not an expert in this, but I was a beneficiary of a surgical mission and program, and this started in 1990, so when we changed in Romania the regime, and I have to say that at that time Romania was a developing country, and the health system was dispirited and dispiriting. This program helped us to change the face of health system in Romania. The program ended in 2006. Why? Because it reached the goals. The program got a lot of support from the US government. This is a program financed by through Humana Foundation and with the help of the US government, and more than 300 volunteers came from Louisville, Kentucky to to train health workers in Romania. More than 300 medical personnel from Romania went to Louisville to be trained. And when I said I'm a beneficiary of this program, yes, I was in one team in 1993. At that time in Romania, the main cardiac surgery was focused on valve surgery due to rheumatic disease. And we introduced after this program coronary artery bypass surgeries and all other kinds of surgery. And the experience of this surgical mission and program, because there were some teams coming from Louisville every in cardiac surgery at least, every 6 months, and they were also mentoring or coaching us, and all the experience from this project you will not find so much in the literature because it's an old program, but you can find this book written by David Jones, who was the founder of Humana, and the Dacian Chronicle. Why Dacian? Because an antique name of Romania is Dacia, and you will find there very nicely described the experiences from both parts, from the visitors and the host. And you see that the key of success are in line with what we think now we should do for this diagonal model of surgical programs. But I would like to highlight the power and unleashing the power of volunteers, which was highlighted in the book. Another important program also in Romania was for developing congenital heart surgery, and you see it started in 2013, and it's still, I didn't put the end of a program because it's still working. We still receive surgical missions from Italy, from San Donato Policlinic San Donato from Milan, and Bambini Cardiopatici of the world, so it's a non-governmental organization. And these surgical missions strengthened the cardiac congenital surgery in Romania. 140 staff were trained. It included fellowships, workshops, mentorships, and now this international mission, in fact, progressed to local mission. People from Bucharest are now going in cities from Romania to develop, to strengthen the cardiac surgical congenital heart surgery. So this is not new, the local mission. In fact, in a report from Operation Smile from before the COVID period, you see that at that time, 67 of the surgical missions provided by them or helped by them were in fact local missions. What does it mean? That the staff is mainly provided by local health workers, and in this way patients can be integrated in the national system, and it's strengthening the surgical system in the country, and it's acting as a temporary measure until the country has the full capacity to perform the surgery. And this is more suitable to middle-income countries. So in countries where there is an acceptable number of surgeons, anesthesiologists, and obstetricians, but there is a big disparity between urban and rural zones. And there is another model I found in the literature, the supervision model. It was published for 3 African countries. And it seems that it works. It's about providing education and training by expert healthcare in referral hospital to providers in district hospitals. And this model, it's suitable for some countries in Africa. And I think that, and I agree with Dolman, who wrote this article on education, the power on education in anesthesia, and I paraphrase his by adding also surgery. I think that anesthesia and surgery can be safely given in low and middle income countries with basic supplies and equipment if the providers are trained and vigilant. And I will not finish this presentation without mentioning another, and Bruce was talking about the importance of research, and I really appreciate this talk and also his role in improving strengthening the healthcare and the surgical capacity in Africa, because I'm convinced that community participation, which is mentioned in capacity building, surgical capacity building in all these studies and frameworks, is also about research. We can improve and strengthen the surgical capacity by research. And why I mention, I'm sure that the ASOS study resulted in improving surgical outcome in many countries on this continent, because I know from my experience, we Romanian anesthesiologists contributed to the 2 European studies on outcome after operation, 7 days after operation, the EUSO study published in 2012, and ISO study, an international one in fact, published in 2016. You see here the mortality after operation in Romania in EUSO study, 6.8, much higher than the mean for Europe. It was in that study 4%, but in northern countries from Europe less than 1%, and it decreased significantly to 1%. And why? Because we were stimulated by these results in the EUSO study to strengthen our surgical and anesthesia capacity, and we worked at the level of Romanian Society of Anesthesia and Intensive Care together with all the colleagues in the country and with the authorities to improve the outcome of patients. So I'm sure that the key of increasing the capacity, surgical capacity all over the world, because it's needed, is empowering the local providers, and only in this way all our efforts will be sustainable. And I finish here by inviting you to please make plans to come to Marrakesh, it's on this continent, in 2026 to the World Congress of Anesthesiologists. Thank you for your attention.
Thank you very much. I'm sorry there is no time for discussion between these talks, because they're so thought-provoking, all of them. But we are looking forward to our next speaker, who is Dr. Nuala Lucas. We know her as a very, what should I say? Fantastic spirit and leader in obstetric anesthesia in the UK and globally. She is a consultant anesthetist in what is your hospital? Northwick Park. Yes, but something which I think is important is that you are a senior editor of the Journal of Obstetric Anesthesia, and should be, and not least, she's a member of the Most Excellent Order of the British Empire, awarded by the then Queen for her contribution during the COVID epidemics. And we are looking forward to listening to you.
I'm really glad I didn't try and leap across the stage there. That might have ended in tears. Thanks, Anthony. It's a real pleasure to be here. It's such an honor to contribute to such a wonderful meeting. Look, I have a small link to the African continent. My husband's South African. So it's a kind of an adopted homeland, and I can't tell you how much affection I feel for everyone here. I also have to say, he's not here, and don't tell him, but he's a way better doctor and anaesthetist than I will ever be, and that's down to his fantastic training and experience in the UK, here in South Africa. Anyway, look, my remit this morning is to talk to you about human factors in anesthesia. Now, I don't claim to be an expert, but I am interested. So what can I tell you? If you think about developments and change in anaesthesia over the last few years, say the last 20 years, we've started to broaden our horizons a bit. You know, these days we don't just think about patient safety in terms of physical terms. We now recognise that patient safety encompasses psychological outcomes. We hear a lot about simulation, qualitative research, well-being and human factors. But all of these things, important as they are, they're rather nebulous and much less well-defined than, you know, advances such as videolaryngoscopy or, you know, some fantastic new drug. And we're anaesthetists, we're very practical scientific people, and I think sometimes it's hard for us to embrace these concepts. And the way I sometimes think about some of these developments, and certainly my attitude, and I don't know if this reflects well on me, but I'm oversharing, is the Kubler-Ross change model, which really is designed to talk about the stages of grief. But I think you can just as easily apply it to some of the concepts, these more nebulous concepts that we're being asked to embrace and understand in anaesthesia. So, you know, first of all, we've got shock, you know. So I remember the first time somebody started talking about human factors at work, and, you know, I just inwardly rolled my eyes and thought, oh, please give me a break. And then, you know, you go through that denial phase. Well, I'm not going to be doing that. That's, you know, I'm an anaesthetist, I'm a scientist, none of that nonsense for me. And then, of course, there started to be a few human factors courses, and people said, well, you have to do this. And there was like, oh, really, frustration that you have to do it. And then I think we've all had a low-grade depression since COVID, which I hope we're fighting back at meetings like this. But then, you know, we do start to embrace things a little bit more. We experiment. Yeah, okay, maybe I do need to take this on, and ultimately we find a way to integrate it into our practice. And look, I was a bit reticent to say my journey. It sounds a bit psychobabblish, but I would say that this does represent what my journey has been with understanding and integrating human factors into my own practice. So I'm going to talk a little bit about the definition and underlying principles. I'm going to talk a little bit about some strategies and things I think you can do tomorrow. What is human factors? It refers to the environmental, organizational factors and human and individual characteristics which influence behavior at work in a way which can affect health and safety. Okay, that's the formal definition. But put more simply, it's making it easy to do the right thing and making it difficult or impossible to do the wrong thing. Now, one thing that I think always gets very confused is the difference between human factors versus non-technical skills. Now, non-technical skills is part of the concept of human factors, but really it's only one small part, and a much bigger aspect of human factors is the design of safe systems. The underlying principles, human factors is fundamentally a discipline that aims to design out the chance of an error occurring and create barriers to prevent that error, if it does occur, causing harm. Now let's talk a little bit about human error. You know, we're all pretty well trained, we're all pretty capable, but we are fallible and we will make errors. And there's a few problems with healthcare. It fundamentally relies on high levels of human performance, and it tends to overestimate our performance. It treats us as clinicians as if we're superhuman, able to act heroically in emergencies. And I want to share a couple of experiences, and I'm sure you've all got similar experiences. I got a call when I was a fairly newly appointed consultant. I got a call at 2 o'clock in the morning from one of the registrars saying, I've got a patient on the table with a hemoglobin of 4 and no blood in the hospital for him. And I remember driving in thinking, what am I going to do here? You know, I don't have some magical biblical quality. And another scenario, again, that middle of the night call, you know that lady that we gave 97 units of blood to 2 weeks ago was making a good recovery? She started to bleed again. And again, you know, driving in the wee small hours, thinking, what can I possibly do? I do not have a cape. I am not a superhero. What else does human error think about? Well, it assumes that we'll always be there, able to detect a problem and immediately take appropriate action. And we can't always be everywhere, and that's a particular problem where you're so short of clinicians in the African continent. And lastly, and I think crucially, it assumes that we will always follow and do the right thing in these scenarios. And no matter how well trained you are, we've all been in situations where we haven't covered ourselves in glory and thought, I wouldn't do that again. So, human error is something we all have to live with, and we have to try and find ways to navigate around human error. Now, let's talk a little bit about performance under pressure. And I hope it's not hubris on my part in representing our specialty, but I think that in general terms, anesthesiologists are pretty good under pressure. And it was certainly one of the reasons I chose anesthesiology. Somebody came up to me in a hospital corridor when I was a very junior doctor, my boss at the time, my surgical boss, and he said, "What do you want to do?" And I said, "Oh, I don't know." And then I thought for a moment, I said, the anaesthetist always seems to know what to do when things go wrong. A little bit of anesthetics won't do me any harm at all. But actually, we don't always perform as well as we might think when we're under pressure. And if I just give you the example of preparing a talk, and I hope it's not just me, but I hope anyone who's prepared a talk at this meeting can relate to this. The month before, oh yeah, no problem, no bother. About a week before, you're really getting into the zone. What am I going to talk about? What are my slides going to look like? And then the night before, oh, why did I not do this before? And I think, we've probably, I've been there. Maybe everyone else hasn't, but I've certainly been there. This is the original figure demonstrating performance under pressure. So it's drawn as a lovely bell-shaped curve. We like bell-shaped curves in anaesthetic practice. And this was the original description by Yerkes and Dodson. Now, I put this up really just to show you a couple of things. I really like the zone of delusion. And I was trying to find a good definition. The only thing I can think of, I'll just give you an example. One of my registrar colleagues cited an intrathecal catheter. He did a dural puncture and he threaded the catheter and he was managing this woman's labor analgesia as an intrathecal catheter. So I said, okay, well, make sure you label it carefully. You've got to give top-ups yourself and blah, blah, blah. We went through all the strategies and all was well. And again, it's almost 1 o'clock in the morning. Why is it almost 1 o'clock in the morning? I get this call. I've just topped up a woman for a section and she stopped breathing. And I said, it's not that woman you put the intrathecal catheter in early on, is it? And he said, oh, it is. And I think, he was probably in the zone of delusion, that 1 o'clock crash section. He just got out his epidural top-up and just gave the full 20 mils. But anyway, now, the other point I want to make about this figure is lots of people say that actually it's not a bell-shaped curve. What happens is that when you reach whatever your maximal point of pressure is, your performance doesn't just decline in a nice bell-shaped wave, it drops off in a much more steep vertical way. So you're doing well, and all of a sudden, you're not doing well. And these are the other sort of concepts, which, it's all variations on a theme, but I think it's worthwhile knowing these points. So in general terms, we're in the zone of flow. We're doing our urology list, we're, as my daughters would say, we're vibing on the labour ward, it's all going nice and smoothly. And then, you get a bit pushed a bit too far. They want you to open a second theatre for the cord prolapse that's just come in via triage, and you're just starting to get a bit frazzled and a bit fatigued. And then, all of a sudden, the woman in room 3 who's just had a lovely vaginal delivery had a torrential bleed. And you've got to manage these scenarios and try and prevent yourself going into the zone of freeze where your performance is going to decline fairly dramatically. Now, there is when I like to think that I have less moments of the zone of freeze than I did when I was a younger, perhaps less experienced anaesthetist. But anyone who's had that zone of freeze or felt like you haven't covered it yourself in glory, I want you not to beat yourself up about it, because there is neurophysiological basis for the way we perform in these scenarios. There's the fight or flight response, cognitive overload, and limbic hijacking. I've got to avoid making any gender references with cognitive overload very carefully. So let's talk about these. So the fight or flight response. Initially, as we all know, we get an increase in adrenaline, increase in cortisol, puts our heart rate up, and we get much more alert. So in general terms, it's a good thing. But if the stress continues, what happens? Our field of vision decreases, we get decreased situational awareness. Our hearing actually goes down, and I don't know if has anyone ever experienced that in that really high pressure situation? And somebody said something to me, and they've said it a couple of times, and I just haven't heard it. And I don't think it's to do with me getting older. I think it's just that I've switched off something at that particular time. And the other thing that happens, and again, I don't know if any of you've noticed this, is, I always pride myself on having a really steady hand. Those art lines, whatever precision thing we're trying to do. But under stress, I have developed a tremor from time to time, and I'm always slightly mortified by it. But it is just a hormonal thing. It's, there's nothing we can do about it. Now, cognitive overload, avoid any gender references. Working memory is a finite size. And has anyone ever read that book, Thinking Fast and Slow? I bet you Bruce has read Thinking Fast and Slow. As he turned off, he's doing his next talk. He's trying to avoid getting frozen. Who's read Thinking Fast and Slow? Yeah, okay. Well, I'm ashamed to say that I've never managed to finish it. It's bedtime reading in terms of it would put you to sleep, but it's pretty heavy going. But people who have read it, and my husband, who's much cleverer than I am, has read it, and they tell me it's a really cracking read and really relevant to anaesthetic practice. But fundamentally, we've got two processing centres. We've got the fast emotional processing centre, that immediate response, but then we've got the analytic, much slower response. But what happens when we get cognitive overload is that the emotional brain processing takes over and we lose our rational thinking. Now, just to take a step aside, I guess what I say to everybody, to new consultants, when I'm talking to them about, how I think they should approach their job, I say, you've had a bad day at work, don't sit down and write an email and copy it to all. Write that email, put it in your drafts folder, come back to it at least 24 hours later, and if you still feel the same, rewrite it, take out the swear words, and then send it. Because who knows what the ono second is? So the ono second is that minuscule amount of time from hitting send and thinking, oh no, I shouldn't have sent that. Okay, so that's the sort of the email version. But in clinical situations, if the emotion takes over, that's not always a good thing. Now, limbic hijacking. Limbic hijacking is an impulsive reaction to sensory stimuli in high-stress situations. The amygdala interprets stress as danger, and it enables somebody to act without modulation. And it's fundamentally an evolutionary advantage, but it does affect our performance detrimentally in a crisis. So those three things, if you have a day and you don't cover yourself in glory, it's physiology, it's not you. Now, how can we integrate human factors into our practice? And there is this, of course, the neuropsychologists have come up with lots of clever things, but fundamentally it's using this hierarchy of controls. Design, barriers, mitigate, and of course, at the cornerstone of everything we do, education. So what we want to do is avoid errors occurring in the first place. We want to decrease our reliance on performance and avoid cognitive overload. We want to prevent errors progressing to harm. We want to manage that cognitive overload, and we want to try to move from the frazzle and freeze zone to the flow zone, and we want to learn from events. So let's talk about design, avoiding error, design of equipment, conditions, and drug ampules. There's lots of examples. I've just pulled out these three. Now, design of equipment. I know that not everyone has VLs, but if there's one piece of kit that I think is really worthwhile getting and lobbying for and asking, borrowing, perhaps not stealing, a video laryngoscope, it's this piece of kit. I think it is one of the most transformative pieces of kits in anaesthetic practice. And why I like it is not just all the data about reducing intubation attempts, blah, blah, blah. I like it because it turns intubation from me or I to we. It makes it a team sport. Somebody else is there visualizing where the tube is going. And how many times have you been supervising a trainee and you're saying, and the tube is going up and down and coming out with a bit of blood, and you're saying, tell me what you can see in your calmest voice that you can manage. And with a video laryngoscope, you can really see what's going on. And it gives you, and if you're working alone, it enables other people to see where that tube is going. So I think VL's are a fantastic device. Design of environment. This is just something I picked up from my hospital. We had a crisis in our hospital. One of the big issues that was identified afterwards was that nobody knew where the emergency call bell was in theatre. It was, all our theatres were constantly being, our theatres are very old and they were done up, and nobody knew where the emergency buzzer was in theatre. So what we've done is we've gone around all our theatres and we've put this big red bit of tape on the wall, so you can, wherever you're working in theatre, you just look for the red tape and you can see where the emergency bell is, and you're not going to lose any time trying to find it. Drug ampules. Now, this is a difficult one and highly relevant in this environment. Look at this, tranexamic acid and bupivacaine, incredibly similar ampules, and there are hundreds of examples of this. Now, we don't manufacture drug ampules, but we are an important voice, and all the sponsors here today, as Anthony said, please go round and say hello to them. As a meeting organizer, I know how crucial they are for the success of a meeting. But go around, look at their products, and if they make drugs, talk to them about this issue. They need to hear from us. They need to know that this is a really significant problem. Now let's move on to some barriers. How do we trap the complications, the errors, if they occur? Well, using non-technical skills routinely during our ordinary working day, checklists, team briefs. Now, I sometimes worry we've got a bit of checklist fatigue, and I think we've got to be cautious in anaesthesia about introducing any more checklists. But there's no doubt that certainly in my hospital, with the constant flux that we have in staff, having a team brief at the beginning of the day, knowing who the random bunch of strangers you're going to be spending the day with, it is incredibly important, particularly in an emergency situation. And of course, flattening the hierarchy. Now, just to talk about regaining a bit of control, what do I think you can do? Well, call for help. And this is drilled into us right from day one of anaesthesia. And I think perhaps as more senior people, you sometimes feel that you can't call for help. But the way it's a really important aspect of being a clinician is not just knowing what you're good at, but also knowing your limitations. And for experienced people, I can't emphasize this enough, nobody thinks the worst of you. Something that I found really helpful is just talking out loud, saying, look, I don't know what's going on here. The sats are falling, the tube's in the right place, and inviting ideas from the team. I think that's incredibly constructive. People talk about this, about regaining your composure, box breathing. Does anyone know what box breathing is? Box breathing is it's basically trying to slow your breathing down, holding it, pause, and breathe out. I have to say that in that sort of crisis situation, I've never actually managed it. My heart rate is generally going too fast, and I'm trying to keep that tremor under control, but people say it's a good strategy. Something which I've, again, found helpful is delegate. Looking around, I think there's a lot of people of a similar vintage to me. And as the boss in these situations, we often feel that we can't delegate. We have to take responsibility for everything. But delegate, you're not there to do it all. And use cognitive aids. And I just pulled these up. These are quick reference manuals from the UK for anaesthetic emergencies. And the OAA one, I work with the OAA, we're going to actually turn that into an app, which is going to be freely available. So when that comes, download that app. Finally, just reduce the consequences when these issues do happen. And who was at Ryan's talk, a case that changed my practice the other day? So Ryan spoke really movingly and eloquently about the impact of a critical incident on an individual. And again, it's one of those softer outcome things that perhaps we're just starting to embrace, but I can't emphasize how important this is. And of course, investigation and learning from events. Just to finish up, these guidelines have been published in the UK. I must acknowledge my friend and colleague Fiona Kelly. She's done a terrific job. Very practical, absolutely not psychobabble, very practical and useful guidelines about how you can integrate these into your practice. Things you can do tomorrow. Think about human factors at work. Where's your emergency buzzer? Is there anything that's been annoying you about the in-theatre environment that you need to fix? If you've got a VL, use it, and if you haven't, lobby hard to get one. The power of first names. I hope no one insists on being called, Professor Sir, blah, 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 but first names are really important. Think out loud verbalize what you're doing in a crisis. It's really helpful. And check out some of the cognitive aids that are available. You know, some of these guidelines are long and turgid, and you're never going to get through them in the emergency. But these cognitive aids distill down the essence of what you need to do. So human factors is more than just technical skills. We can't rely on human performance alone. Even the best of us have days when we don't cover ourselves in glory. Human factors, strategies, avoid, trap, and mitigate an error. And it's not just psychobabble. We should be integrating human factors and non-technical skills daily into our practice. Thanks again for listening. Yeah.
Thank you very much. Fantastic topics. Our next speaker is, I can't see her. Oh, okay. Our next speaker is Professor Salome Maswime, an old friend. She is the head of Global Surgery Division at UCT. She's an obstetrician and gynecologist, a good friend of anesthesia for a long time. She is currently the chairperson of the Health Systems Trust and a member of the Global Governance Council of Lifebox, and just recently has been appointed as the lead of the whole World Health Organization Collaborating Center for Integrated Clinical Care. A round of applause for Salome. She's going to speak to us on African maternal mortality. Welcome, Salome.
Thank you so much, and greetings. It's such a privilege and honor to be here today. Friend of anesthesia. I'm still hoping one day that honorary anesthesia title will come. I happen to be an obstetrician employed by the surgeons and a great friend of anesthesia. So at least the language I'll speak today, I think you'll all understand. It's not, it's not like when we used to fight at 2 o'clock in the morning, as obstetricians and anesthetists often do. But I'm going to talk about really the work that I've done over the last few years and just how this has led to a program, firstly in global surgery, but also how we're trying to reduce maternal mortality in Africa. Okay. Which direction? Okay, cool. All right, so, I mean, the numbers are there, the stats are there, but I thought I'd start off by talking about my own personal experience about 20 years ago when I was starting my career, where I was working in a rural hospital in South Africa. I won't mention the province, but at that time, when you had a cesarean section, and we know cesarean section is the most widely performed operation in the world. And so when you did a cesarean section, you'd scrub and wear 3 sets of gloves. The first set was to do the spinal, then you'll take it off and then do the Caesar. The midwife would be would be on the other side. So if there's any anesthetic issues, she'd be the one that would attend to them whilst you're cutting without an assistant. Again, you're working with another midwife who's assisting you, and if anything happens to the baby, then you need to decide whether to let the midwife continue while you look at the baby. And so the reality was, we were doing these as medical officers, as junior medical officers. You're responsible for the anesthesia, for the cesarean section, and also for the pediatric outcome. If the mother or the baby had a complication, you really didn't know what to do, right? That was the reality. And I thought, after I think the 2 maternal deaths that convinced me to specialize in obstetrics and gynae was a high spinal, and because none of us were trained to do general anesthesia, no one ensured that we knew what to do. And so one doctor in our hospital knew how to do it. So if there was any anesthetic complication, any time of day or night, she would be called. And so we were in a morning meeting when she was called to theater. They managed to do a GA, but the patient still had severe complications and needed to be taken to the tertiary hospital 72 kilometers away. And so the decision was made to airlift the patient because to get her there sooner. But whilst waiting for the helicopter to come, which took 8 hours, the patient died. And so perhaps it would have been better to get her there in an ambulance earlier in the morning. We don't know if it would have arrived. Perhaps it would have been better to train us, as young medical officers, how to look after anesthetic and obstetric complications. No one knows, but the patients did not live to tell the story. So what do we know about maternal mortality? I always like to highlight that in many parts of the world, having a baby, falling pregnant, is still one of the most dangerous things a woman can do. We've got 280, about close to 300,000 maternal deaths worldwide, and these have come down every year. They've come down, but we're still very far from achieving the targets that we should have. Africa, of course, we've got the highest rate of maternal deaths in the world, and this is in countries where there are fewer anesthetists. The maternal mortality rates are higher. If you look at MMRs by country, I think you need to also just ask how many anesthetists are in that country. And in those countries where there's 2 or 3 anesthetists, you'll find the maternal mortality rates are also much higher than in countries where there are more anesthetists. But what's also happening in some high-income countries, maternal mortality rates are going up as well. And many reasons, which we won't go into today, but maternal mortality rates are not, on a downward trend for everyone. Even in countries that are well-resourced, we're having challenges as it is. We know the causes of death: hemorrhage, hypertension, sepsis, underlying medical diseases, underlying infections. And we also know the numbers, the stats that were presented earlier by Bruce. These are horrifying stats. These are horrifying numbers, because what it really tells you is where you are in the world really matters at the time of childbirth, at the time of having your cesarean section. Had you been in any other hospital, you would have survived. And again, it's not just the mothers who die. Where the mothers die, the babies are also likely to die. So what are the drivers of poor maternal outcome? We start off with the status of women in society, inequity and inequality. It's access and acceptability. What is the patient experience? And then the quality and safety. What's the availability? What services are available? And what is the affordability of care? We also know about the determinants of health. We often speak about the social and economic. I say those we used to blame the patients for their poor outcomes, but we also need to think about the political, where the governments make decisions and don't allocate the right resources or enough finances for us to be able to run the kind of healthcare services that we want to run. But unfortunately, most of us who are trained from a biological perspective, and we are trained how to manage the patient. And we put a lot of emphasis into being great doctors, great anesthetists, great obstetricians and gynecologists. But at the end of the day, if you're working in a system that's not functional, doesn't matter how excellent you are, you're only as good as your system. If you look at the numbers of surgeons, anesthetists, and obstetricians, the places with the highest maternal mortality rates have the lowest number of surgeons, anesthetists, and obstetricians. Maternal health, of course, when we talk about health, it's about ensuring that people reach their full well-being, have great outcomes. It's about providing the services that people need, basic antenatal care, ensuring surgery is safe, etc. But we also know that looking after a sick patient, it's not the healthy patient that's gonna die, it's the sickest patient. And so what are our systems to look after our sickest patient as the patient deteriorates and goes from organ dysfunction to organ failure, eventually to death? That's a process on its own. And if the system is not prepared to look after the sickest, then those patients are not going to survive. So we know the causes of maternal mortality are ultimately linked to lack of access to care, delayed access, where there's a shortage of specialists and multidisciplinary team, shortage of equipment, resources, poor preoperative and post-operative care, poor infrastructure. But what are the anesthesia-related factors to maternal mortality? And so I'm going to pull out 3 different sources. Here I looked at a number of papers that spoke about the South African experience, looking at anesthetic deaths. The first thing was that majority of the deaths occurred in district hospitals. So I know many of us in this room do not work in district hospitals. If anything, maybe there's some outreach or enrich that happens, but ultimately the majority of patients that are going to die are going to die in district hospitals because the doctors, like me, when I started, are not able to look after the sickest patients. And even though there may be systems to refer the patients to higher levels of care, those systems may not be readily available or accessible for the patients. So what can we do as an anesthetic community to enable those that are looking after the patients to provide better care for them? You know, a lot of our arguments are around strengthening anesthetic care in tertiary hospitals, and yes, that's very important, but what are we doing for those that are looking after these patients? Because the patient doesn't choose where to have complications based on who's working there. Patients are going to have complications with or without us, but those who are looking after them need to have systems in place so that patients are not dying in their hands. And then, as I said, medical officers are not trained to manage the complications. And then there is a shortage of anesthetists all around, you know, across the continent. There is a huge shortage of anesthetists. But then another interesting factor was the lack of anesthetists trained in system strengthening, because ultimately it's not just about how well clinically you trained, it's about how you're able to make decisions that will impact on patient outcomes. And so there's a special need for systems strengthening training. Global surgery luckily starts to provide that and to teach that. And so it's important that anesthetists are engaged more in system strengthening. I want to quote a paper that we wrote with my old friend, Prof. Mochavi. And in this study, we're looking at maternal near misses. And ultimately, we wanted to look at the anesthetic outcomes and what drove the anesthetic outcomes. So in this study, we found that this was here in Johannesburg, 1 in 80 women were classified as maternal near misses. Women who had cesarean section, 1 in 4 of the near misses required a relook laparotomy. So we know this is not something that only an obstetrician can manage. We found that fluid resuscitation and medical management and non-invasive procedures were able to arrest the hemorrhage in most of these cases, and so reducing the need for hysterectomy. I think, in fact, only about 7% required a hysterectomy, which showed that with fluid resuscitation, great medical management, and a supportive anesthetist, outcomes were better for our patients. So I looked at the American Society recommendations for anesthesiologists, and you'll see I use the word anesthetist and anesthesiologist interchangeably because we know in different countries we use the words differently, so I'm referring to what is called an anesthesiologist. And some of the interesting facts that came, or recommendations that came out of this was, whilst the cause of anesthesia-related deaths is very low, so I think it's usually about 0.5%, less than 1% contribution, but the opportunities for anesthetists to reduce morbidity and mortality are high, because the patients ultimately are going to have complications related to hemorrhage, embolism, cerebrovascular accidents, hypertensive disorders. I hate to say it, but us as obstetricians are not always the best at managing some of these complications. And so when we call you late at night asking for help, it also has to do with the skill set that anesthetists have, in addition to in being able to look after the medical complications, the critical care complications, and all the other things. The evidence supports that anesthetists are instrumental in providing safe obstetric care through the management of difficult airways, placement of vascular access, and massive blood administration in the labor and delivery unit. And the conclusion was that anesthetists are often experts with experience in perioperative medicine, critical care medicine, systems engineering, and safety. And because of this, the value of that the anesthetists provide actually reduces maternal morbidity and mortality. But I also wanted to touch on obstetric transition, which is how do you address maternal mortality in countries which have high MMRs compared to countries which are almost eradicating maternal mortality? Your interventions will be different. In countries where there are so many where the causes of death are directly linked to excess, your interventions may have to do with health education, community education, basic infrastructure, just ensuring that your sickest patients are able to get to a hospital in places where there aren't even roads. But which is very different in places where you've got the infrastructure, the mortality is low, you've got more near misses, and you're trying basically to improve the outcomes. So the approach needs to be very different. And at the end of the day, as obstetricians, as anesthetists, we all need to be thinking both about the systems interventions that are non-medical, that are all about systems, whilst also thinking about quality improvement inside of the hospital. We look at global surgery as this interface between surgical services, health systems, and governance, meaning you have to think about the public health specialists, you have to think about the politicians and the decision makers, and how you can persuade them to invest more resources in surgery. The interventions that we promote is advocacy, quality improvement, which will speak to all of these interventions that we do inside of the hospital to improve the safety and quality of care, community engagement outside of the hospital, capacity building, teaching the medical officers, improving training, and then policy engagement. And who has the time between your busy theater slates to do all of these things? But either way, somebody has to do it. So there are two recommendations that I have for this particular community that I think if we focus on those on these two areas, we'll be able to reduce maternal mortality together. The first one is capacity to rescue. And capacity to rescue reminds us that complications will happen. The issue is not just the occurrence of complications, it's that our health systems are able to manage and are prepared for those complications as they occur. And so we have to improve our ability to manage the sickest patients and to be prepared for that. Whether it's in a district hospital, a secondary hospital, or a tertiary hospital, meaning we have to think about who is capacitating the medical officers whilst thinking about how we make our flow of patients and care better in tertiary hospitals. Should obstetricians rotate in anesthesia just to learn how to put up CVP lines? I'll leave that to you to decide. But the other recommendation I have is surgical leadership. As I mentioned, system strengthening is becoming a core part of what we do. And I think we don't have as much of a surgery problem as we have a leadership problem. It's how we organize resources, it's how we make our decisions, it's how we decide whether theater is going to start at 8 in the morning or at 10:10 after everyone has had their tea and breakfast and everything. These are decisions that human beings make. It's not, you know, we don't start our theaters late and cancel all the electives because it's how it is. It's because of leadership issues and how do we work together to improve. So we run an executive leadership course in global surgery through our graduate business school, and I've seen a number of people in the room who we're very proud to have been part of this course and are continuing to do quality improvement work and capacity building in their own areas. So in closing, I think we can improve maternal mortality in Africa if we work together. We have to bridge the gap between services and systems. Thank you very much.
Thank you very much, Salome, to that inspiring talk. Our next speaker should come up. So I need to take a deep breath to introduce this speaker. Our next speaker is Stan, Professor Stanton Shannon, from the Brigham and Women Hospital at Harvard. He epitomizes mentorship. He's a cardiac anesthesiologist, and I acknowledge that we have cardiac anesthesia guests international, so it's very close to my heart. He is a cardiac anesthesiologist. He is a past president of the SCA and has served on many boards. That's not important. The important part is this is a symbol of kindness, mentorship, reaching out no matter where you are, whether you're in Africa or whether you are in an affluent society, anywhere. This person here is the invited guest of the society. 14 years ago, I met him probably for 30 minutes. And then he stuck himself with a needle. So he had a bad day after that, so I was even scared to speak to him. But 2 years later, he followed me into Africa, and we had our very first perioperative cardiac anesthesia congress at the back of Bara with no aircon. If I showed you pictures of how we had fans blowing the whole room because we had no aircons in that room, it was amazing. And he's been coming to South Africa since. It is because of him that Africa had the very first international Congress of Anesthesia last year in Cape Town. So a big round of applause for Stan.
Well, I've done a lot of things giving a lecture before, but I never cried at the beginning, so. Is box breathing? Yes, box breathing, all right. Mentorship in academic medicine. My own disclosure is I never was fortunate to have an academic mentor, and hence the reason why I'm so passionate about this topic. If you look at the definition in Merriam-Webster's dictionary, it says a mentor is a trusted counselor or guide, someone who helps you with your career, specific work projects, or general life advice out of the goodness of his or her heart. But I'm wondering who in this room considers themselves a mentor. You don't have to raise your hand if you don't want to, because I'll challenge it by saying that mentors are not self-defined. Mentors are defined and chosen by others. There's no mentorship school. And perhaps we are born with certain characteristics, but it takes, as you'll hear, a lot of training. If you look historically at mentors, some would say Moses is a mentor. Mentor was actually a figure in Greek mythology. Merlin supposedly was King Arthur's mentor. I'll have you notice that they're all men. And they all happen to be, men. But I would therefore suggest that a mentor is someone who sees more potential, talent, and the ability in you than you see in yourself, and enables you to become the best you can be. And if you think of it that way in your own personal lives, you've probably had many mentors, from teachers, athletic coaches, business partners, physicians, clergy, and if you're really fortunate, one of your parents. They all share things in common, characteristics of wisdom, experience, spirituality, respect, patient, admirable, compassionate, self-sacrificing, and iconic. But in fact, there are many different types of mentors that you may experience in your life. And it's always a two-way street, a dyadic relationship between you and the mentor. So you just can't go up to a mentor necessarily and say, can you help me? It really goes both ways. Advice is accepted, rejected, matured over time. The first type of mentor you may encounter is the master of craft. This is the Jedi master, if you will, someone who's accumulated their wisdom through years of experience and who can provide insight into your industry and fine-tune your skills. Their job is really to make you the best you can be, sometimes at all costs and quite a bit of sacrifice. The second type of mentor is the champion of your cause. These are usually sponsors, people who facilitate networking. So you may not have that personal relationship interaction, but they're the ones who maybe a month or two after you spoke to them says, I've got something for you if you want to help yourself. I contacted so-and-so and they're going to give you a call. Mentor number 3 is a co-pilot. It's almost like a buddy. A colleague can talk you through projects, advise you in navigating the personalities in your company, listen to you vent over coffee. And what's unique about this type of mentorship is sometimes it's equally reciprocal. Kind of help each other in many ways, and you may not even realize it until each of you have come to that point in your career. The fourth type of anchor is the anchor. And it differs from the first one I mentioned, the champion. While the champion supports you to achieve specific career goals, your anchor is a confidant and a sounding board, someone who can provide a psychological lift and help you see the light during those challenging times, like trying to achieve work-life balances. Say, you're doing too much. You got to draw back. I can see that you're stressed. The fifth is reverse mentor, and you probably haven't thought about it. The fifth is often your mentee. Who could critique you best on your skills than the recipient of your knowledge and the recipient of your efforts? So listen to your mentees if you want to become a better mentor. Now, this one's mine. You can take it or leave it. That's why I say it's the sixth. I call it the Cheshire Cat. If any of you are not familiar with Alice in Wonderland, she comes to a fork in the road. She looks up in the tree, and there's a cat up in the tree who talks, of course. And she asks the cat, which road do I take? The cat says, where are you going? She says, I don't know. So he says, well, then any road will take you there. And so what I try really hard to do as a mentor, certainly in that first date, if you will, is just listen. And my first words that come out of my mouth are always, tell me more. And it's so hard as a mentor to resist wanting to do something. You want to help. That's what makes you happy. It's not about you. It's about the person who may be anxious sitting right across from you. So listen and ask questions. How to develop mentors? It's really hard. As I said, there's no real mentorship school. You can read books and you can read papers, but it takes a long time and a tremendous effort. Tip 1, mentors need clear expectations of their roles and enhanced listening and feedback skills. They're not born. You may come with some inherent skills, but it really takes honing over time, willing to learn to be criticized, and willing to learn to develop yourself over time. Tip 2, mentors need awareness of culture and gender issues. I don't think mentors should be forced to deal with mentees who look like them and are their own sex or gender. In fact, it may be worthwhile to challenge yourself and them to become used to dealing with people who don't look like you. You'll learn to overcome any biases, which we all have. We're all born with biases. So take that in consideration, which path you might want to take. Tip number 3, mentors need to support their mentees, but challenge them too. It takes a balance of these 3 elements: support, challenge, and vision of the protege's future. If mentors are overly supportive without challenging mentees, the mentees don't grow professionally. But if you don't challenge, if challenging without support causes mentees to regress in their professional development, that really doesn't help either. Tip 4, mentors need to be aware of boundaries. They should stick to mentoring and respect personal boundaries in their mentee relationships, including recognizing psychosocial problems that need referral to other professionals such as psychologists or counselors. If you see yourself hearing something, maybe about a harassment issue, maybe about an issue of substance abuse by your mentee, and you're starting to feel uncomfortable, your breathing rate's starting to go up, you need to be comfortable referring them elsewhere if it's outside your area. Tip 5, mentors also need mentoring. Mentor for mentors, coaches. I had a coach, wasn't happy about it, but I was forced to do it, and it was the best thing that ever happened in my life, because she was able to tell me things that I actually was not comfortable speaking about. She was able to help me develop myself and with my own frustrations. One of the best experiences ever. So again, consider coaching as well as part of your role in being a better mentor. Tip 5, mentors are still human. They do need recognition, raise the value of mentoring, and even though the inherent, if you will, benefits shouldn't be financial, they still should be recognized within the department. Everybody likes a gold star and a pat on the back. It's what makes us better to a certain extent. And then tip number 7, I tried to suggest that there's more than just one type of mentoring. There's also a time component to this, namely a hierarchy of mentors, not only from junior to senior, but also over time, that will act as a team for an individual. And the individual may feel better talking to a junior mentor, someone who they believe can relate more to them at times, and then yet it's senior mentorship, someone who can feel comfortable being stern and critical. And so really mentoring for an individual is a team effort over a time period. A mentor can be harmful, one that insists that a mentee become a clone and can only work within a mentor's research area and or publish with the mentor. It's hard to resist that as a mentor, but again, this person does not come to you as your slave. It's not about you, it's about them. The mentor doesn't provide sufficient time for mentoring relationship or adequate encouragement for the mentee. Remember, it's this balance of challenging them and supporting them. And when you make that call, really can make a difference in that relationship. Very important third point here, the mentor doesn't support a mentee from leaving their current role or institution when their relationship is no longer productive. All mentor-mentee relationships have a time course. And when you see that and recognize it, it's your role not only to let them leave, but to promote them leaving to become better people. Remember, your job is to make them the best they can be, with or without you. And it can be one of the most difficult challenges of being an excellent mentor. There are rewards. There are formal mentoring awards, time or funding. Assisting the next generation is a gratifying altruistic reward. Gratitude from helping the next generation of leaders. And then receiving assistance from mentees may help advance your productivity and career and can contribute to legacy and professional immortality. And I would think perhaps that's one of all of our vulnerabilities, is to live forever in one shape or form. But I've said perhaps one of the greatest goals I'd like to achieve in my career, and I'm getting close, is to sit at the back of the room very quietly, be the last to enter the room, watch my mentee get up on stage, surpass me in knowledge and prominence in their field, and then I quietly exit from the back of the room. The rewards of mentorship, it's not just a responsibility, it's an extraordinary honor. Thank you.
Well, thank you everybody. There is time for comments and questions. So please everybody, if you have some comments or questions, to which there are many for every lecture here. So try to think back and come up and discuss with the speakers. Maybe I can start with one for Bruce. Bruce, I have a question for you, and that is when we talk about Africa and what you do in Africa for research. As we know, like when people in Europe, they go to Africa, and then the next question, well, where in Africa? Because Africa is so huge and so diverse. So what kind of reflections do you do about the diversity when you do the African studies? Do you understand what I'm referring to?
Sorry, Annika, I didn't hear the whole question.
No, my question is when we talk about African outcome studies and research in Africa, but Africa is a huge continent, and it's not the same all over, even though some Europeans, when they go to a country in Africa, they say they go to Africa.
So Jannica, the approach we've taken is to look at the most simple, generalizable signals that we can find. So with limited resources, our feeling was we'll try and look for things which are applicable in most of the environments in Africa. Certainly what you're speaking to is important because when we looked at the priorities, you know, that the example of national priorities and continental priorities, how they change, and that's because of resources and other things. But at the continental level, we're still just looking very simply at simple interventions to improve outcome. But certainly it doesn't mean every country is the same. But the signals that sort of APOG have put out are consistent, and there's no country which stands out as performing significantly better or worse in those signals.
Thank you.
Thank you very much. Is there any other question for any of the speakers? We do have about 10 minutes. There's a speaker. Can we get a mic to?
No, but they are over there. Just stand behind each other over there, and you can come here too. So there's first you with a nice colored shirt.
So, good morning, everyone. My name is Mzulungile, not Digida. I'm a doctor by training. And I've received training in a different environment than South Africa. But I think the speaker who spoke before the last speaker, I think the specialist in obstetrics. Yes.
Saloma?
Yes, she made mention of a leadership training that is available for medics. And I guess that makes perfect sense, especially for those ones who have left the medical school already, to be able to train themselves in leadership. But is there any effort from the, let's say, the Society of Anesthesia to consider advocating for possible incorporation of leadership training and finance or entrepreneurship training at med school, so that the guys who are coming out of that med school from maybe a year from now, at least they are trained in leadership, and it's not starting from scratch when they have qualified as doctors. And the last part is just to thank the last speaker on I think for me that was the take home on mentorship, that really it is not about you as the mentor, it's about the person that you are mentoring. So if you can sit at the back and you can see them even surpassing you, that for me was the take home message. Thank you very much.
Can we get a speaker to Salome? A mic, I mean, yeah.
Thank you. I'll answer my part, but the question was specifically to the council, so I'll let you answer the other part. there's a real gap in medical training on leadership. And the more we're doing this, the more we realize how important, because leadership is taught by the business schools, right? And that's the domain. Even when we tried to introduce some leadership courses into the public health department, they said, no, that's not our domain. The domain is the leadership school. You know, to do a course in the leadership school, one, it's so expensive, you need to be sort of towards the end of your career, which is too late, because these leaders become leaders way before they can afford even leadership training. So there's a serious gap. We are trying to address it. We are teaching global surgery very basic to 5th and 6th years, but we haven't gotten to a point where we're able to bring leadership curriculums into undergrad training. And I think we all need to advocate for this to be done more and more across the world.
Thank you. If we can just get a comment from...
Yes, just to add that we at the WFSA, we are acknowledging the gap in leadership training, and we are established a group for looking for a curriculum in leadership training and to start a course on leadership for anesthesiologists, and I hope that we'll launch this course in Marrakesh. So it's very ambitious because it's a short time, but for sure we'll have some news for you regarding this, because as you mentioned, these courses usually are related to business and are very expensive. So that's why we felt that we have to work together with our national societies to establish a course in WFSA.
Just to clarify, Bisola, are you following up on the comment, or is it a different question?
Not a question, comments, follow up on comments, on some
Leadership.
comments.
On the leadership. Oh, okay, let's get
thank
a
you
new
very
question
much.
then.
My name is Henry. I'm coming from Nigeria. My comment question goes to the President WFSA. It has to do with medical missions. I will start with a story that most of us are familiar with. In 1996, there was a medical mission to Nigeria by one of the big pharmaceutical companies. They came in the form of mass immunization. It turned out that this wasn't immunization, and about 10% of the children that underwent the immunization program, they had complications and some died. The case is still in court up to today. So, and then the other incident of an NGO that came for eye surgeries. They did the surgery and then the next day they left. About 5 to 10% of those patients are now blind. Again, the question now becomes, could these NGOs, could they not be held accountable just like they would have been held in the countries where they come from? And two, even though it's a charity program, it's a free mission, could there not be, through the WHO, tight control, having in mind these two instances that I've mentioned? Thank you.
Thank you for the question.
Thank you for your comments, and I alluded to this in my presentation, that sometimes the outcome of these surgical missions, it's not so good, and it's worse than in other countries. But this is a problem I saw in the literature, because I told you I'm not an expert in surgical missions. This is the most important thing now, accountability. So all these non-governmental organizations should be accountable for this project. But we, in the WFSA, we are not providing surgical missions. Our main role is to advocate for anesthesiology and for patient safety, to collaborate with all our member societies and to educate. So, but we are in contact with this kind of organizations providing surgical missions, and we can help with the educational part of this mission. But usually, it's not our role how they report the outcomes and the quality of the mission.
If I may just add to what you said, because we have this term medical tourism, and that means tourists going to have surgery, but there is another form of medical tourism, physicians and going for tourism and trying to do some help at the same time. And then it should be remembered, first, do no harm. And as you say, the WFSA is working with people on the ground, but first do no harm, I think is important to remember. Bisola.
Yeah, thank you very much. Yes, I just want to say a few things about Africa. Bruce, the first question is that Africa has 55 countries. Is it 54, 55 countries? And we have a population of 1.5 billion, as well as we're arranged in 5 regions: the North, South, East, West, and Central Africa, plus one more, diaspora. And South Africa, I understand you have 12 languages, 11 plus 1, which is a sign. Nigeria, where I come from, we have 265 languages. Just to let you know how diverse it is. You know, that's the first question you asked, Bruce, about the diversity in Africa. So we're diverse. In terms of leadership, I just want to say that leadership is influence. It's very nice to be trained and to have all the, ways of leading and stuff like that. If you don't understand your style of leadership, and if you're not responsible, and you don't take the opportunities to lead, it's an action. It's influence. We can't just sit down and say, yes, I have a PhD in leadership, and I don't play any leadership role. So leadership really is an action. It's something that you take depending on the situation. And there are so many, many, many types of leadership and the way you would use it. So that's a big topic on its own. And finally, I just want to talk about policies. You did mention about doctors taking part in policies and stuff like that. Yes, we are fantastic when it comes to our skills, and where we work. But when it comes to systems, we really have some deficiencies there. And that is why we should get more involved and understand that no matter how skillful we are, we can't make an impact if we are navel-gazing, looking down and not seeing the political issues and all the other things being involved in global surgical obstetrics, trauma, and anesthesia care, and knowing about what is happening and how we can be involved and how we can, make decisions and influence our health services in our different countries. Thank you.
Thank you very much. Thank you very much. I think we've just been over time, 2 minutes, so this will be the end of the session. Thank you so much for everybody who woke up early and got to this session. And thank you to the speakers. Another round of applause.
And to you.
Thank you.